Welcome to our webinar, Ask the Pediatric Expert. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you're unable to view the program online, please call in to listen to the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 3 to 5 business days. You will be notified by email when it is live and ready for viewing. This is an interactive session where Dr. Oved will be answering questions that were sent in advance and the questions being asked on our webinar today. We'll do our best to get to everyone's questions today. To submit your question or comment, please use the Q&A window in the lower part of your screen. Type your question in the small text box window, and when you have finished typing, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help us manage your incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Our specialist today is Joseph Oved. Dr. Oved is a pediatric hematologist oncologist on the Memorial Sloan Kettering Kids team. He specializes in the use of stem cell bone marrow transplantation and cellular therapies to cure non-cancerous diseases. He focuses on transplantation to cure patients with hard to treat immune dysfunctions or inherited immune deficiencies, as well as those with bone marrow failure syndromes. In addition to caring for patients, he conducts research to help advance the field. Dr. Oved focuses on new ways to personalize transplantation to achieve a precise cure with minimal side effects. It's my extreme pleasure to welcome Dr. Oved. Thank you so much for joining us today.
Thank you for inviting me, and thank you for the introduction.
Thank you. So we'll go with our first question. What is the difference between a bone marrow transplant and a stem cell transplant?
So that's a great question, and sort of its nomenclature, but the difference is a bone marrow transplant is harvested from the bone marrow, where we stick 2 needles into the back of the hip bones and we actually pull out the bone marrow itself. And generally when we do that, we don't manipulate the marrow. It's sort of just stored, processed, and then given as a transplant. Another mode for getting stem cells from a donor, though, however, is if we give a medication called GCSF to the donor for a few days. And what happens there is because a significant number of stem cells to divide and then leave the bone marrow and go into the periphery. And what we can do with that is then connect a catheter to the donor and collect the stem cells. In that case, we'll sometimes do what's called a graft manipulation, so that we make sure that we give only the stem cells or stem cells plus a few other types of cells. And that's a second way where we can get stem cells into a patient. So some people will use the term stem cell transplant to encompass both bone marrow and stem cell transplant, but the key difference is where the stem cells are being derived from.
Thank you. And does the patient contribute to how they would like, whether it's a bone marrow transplant or a stem cell, or is that something that the doctor determines?
So oftentimes it depends on several things. The first is, what donor is available. So generally with a matched sibling donor, I would say the great majority of centers would do a conventional unmanipulated bone marrow transplant from the sibling. When we start thinking about matched unrelated donors, mismatched unrelated donors, and haploidentical donors, however, different centers would prefer different modes of transplant. And so some centers would prefer that the mismatches in the matched unrelated donors would be peripheral stem cells, and some centers would prefer bone marrow. And the reason for that is really which centers prefer graft engineering versus something called post-transplant cyclophosphamide. So if you have a setup in your system where you can engineer the graft and pull out different cell populations before you give the graft, you may prefer a stem cell transplant. If you're going to use a haploidentical donor and do post-transplant cyclophosphamide, however, you may prefer the bone marrow instead. The other thing to consider is the donor preference as well. So some donors have a strong preference that they only want to donate either marrow or peripheral stem cells. And if they're the best match, they actually may dictate which type of graft we're going to get. And then we work with what we're able to achieve. Oftentimes donors are amenable to both, but sometimes they prefer one over the other.
Thank you. And how does a physician and the parents, and including the patient too, if they're able to, how do they decide between undergoing immune suppression therapy such as ATG or deciding to go to transplant?
So that is the age-old question in aplastic anemia. And I think, and to take it with a grain of salt, because I am a transplanter, so, I think if you talk to a transplanter, they will lean heavily for transplant. And if you talk to a hematologist, they may lean heavily towards immune suppression therapy. But I really think at this point in time that much of this decision is really the comfort level of the parents and the family and sort of the priorities that they have at that point in time. So if a matched sibling donor is available, I think everybody would agree that a matched sibling donor transplant is the standard of care and the gold standard for aplastic anemia. If you do not, however, have a matched sibling donor transplant, it's a little bit murkier. Some centers are now making upfront transplant standard of care because the results and the cure rates with transplant have been so great over the past several years. However, there is a national multi-center, I think at last count, about 52 centers are participating in a phase 3 trial looking at this exact question as to whether immune suppression therapy or transplant is a better upfront option if there is no matched sibling donor available. And if you were to enroll on that trial, you would get randomized to either immune suppression therapy or unrelated donor transplant. And they are evaluating which has long-term benefit for the patient over the other. In my practice, the way I view this, and this was something that was taught to me by my mentor, I think it's important for the family to have a very prominent say in this particular regard. And how I usually advise parents and the patients is, if you are averse to a 6-week stay in the hospital to short-term toxicity, which is a real concern with transplant in the short term, then immune suppression therapy may be appropriate for your family. If you want a cure, you want to really just be done with this episode in your life, and you want to move on and not think about it anymore, then transplant may be appropriate for your family. And if you don't feel that strongly about either of them, then if the transit study that I just mentioned is open at your site, you might be an ideal candidate for the randomization, so that selection is sort of taken out of your hands. Now, I will say there are other factors that go into this decision. Again, an appropriate donor needs to be identified and willing to donate. And what an appropriate donor looks like at different centers might be slightly different. So some centers may prefer 9 out of 10 mismatched unrelated donor. Some centers may prefer a haploidentical donor. So all those things need to be taken into account when discussing the different options. But in general, that is my approach. So present the two options, sort of go over what each entails, and give the family and empower the family the tools to really make that decision with our support and guidance.
Thank you. If someone were to decide for aplastic anemia that they would like to go with ATG first, does that prohibit a transplant in the future?
So not at all. We have many patients that have gotten immune suppression therapy that have either not responded to it and then went for transplant, or had a partial response and were controlled for either several months or several years and eventually lost that response and then went for transplant as well. So by getting upfront IST, that in no way precludes you from availing yourself for a bone marrow or stem cell transplant, provided that you meet all the other criteria for that transplant.
Great. When should you consider a cord blood transplant?
So that's another excellent question. And I think, again, is center specific. So centers that have a lot of experience with cords may prefer to think about a cord as a more upfront therapy, not as the upfront therapy, but higher in the hierarchy of graft sources. And we approach cords similarly to how we would approach other donors, right? So if we think about the mismatched unrelated donors or the matched unrelated donors, we look at the 10 or 8 HLA alleles that are important and try to match as close as possible. So with cords, it's the same sort of situation. So at our center, for instance, for any non-malignant disease, a cord would only be an option if we had a 6 of 8 match or better, right? So we would not consider less than a 6 of 8 match for a non-malignant transplant. So I think, again, it depends on what your donor availability is, what your center experience with cords are, what your cord availability is, and taking all of those things into account to determine which graft, which regimen is the most appropriate for you.
Thank you. Is there a preference of male donors versus female donors?
So there is, and in the setting of bone marrow or stem cell transplant, transplanters prefer to use young male donors. And the reason for that is that females get pregnant and can have their immune system recognize certain antigens. So they're sensitized to certain foreign antigens, in quotes, from the fetus. And so if you have a female that's had multiple pregnancies, it makes getting the graft in and minimizing complications from the graft a little bit harder for us. And so if all other things being equal, we can get a young male donor. Those are generally the ones we would prefer, provided that the allele matching is comparable.
Thank you. Our next question is, why does my doctor say 10 out of 10 and I hear others say 8 out of 8?
So it's a great question. And it's not because we just love to confuse everyone, but so if you look at the sort of when we do matching, we actually have 6 alleles that we look at, right? And there's an allele from mom and an allele from dad. So 12 that we look at. And these are the A, B, and C alleles, as well as the DQ, DR, and DP alleles. And most centers at this point don't look at DP because we've realized that it's not as important for getting the graft in and for preventing graft versus host disease. And so that's where 10 out of 10 came from, right? So we have 5 alleles left. We have 2 for each allele, and that's 10 out of 10. Now, many centers feel that the DQ allele is also not as important for those same reasons. And so those centers will oftentimes refer to something as an 8 of 8 or a 7 of 8. That said, a 7 of 8 can be a 9 of 10, or it can be an 8 of 10, depending on which allele is the mismatch. So oftentimes many centers will say 7 of 8, and then in parentheses say, oh, it's a 9 of 10 or an 8 of 10. And obviously we prefer for it to be a 9 of 10, but at many centers, a 7 of 8 would be more than sufficient to move forward with transplant.
Thank you. Our next question is, when are you considered cured after having a transplant?
So the cure is essentially getting the graft in, maintaining the graft, and not losing the graft. And so oftentimes we know by 1 year post-transplant that your chimerism is stable or good, that your immune function is back, that you're starting to get revaccinated. And that's sort of the cutoff that I give most families as this is, really when things go back to normal or as normal as they can be these days. And this is really the time where I'm less worried about, aplastic anemia related complications. And we're sort of just, catching up on vaccines and things like that.
Thank you. Speaking of vaccines, will the COVID-19 vaccine become part of the vaccine schedule after you've had a transplant for those who would be eligible?
Again, I think that that's going to be center specific. We have implemented it as part of our vaccine schedule. However, we've also left it optional to families to decline that particular vaccine. We've also offered that vaccine earlier than other vaccines, given the prevalence of COVID-19. And so even if your immune system is not fully reconstituted, we have been offering at least the first 2 doses and maybe even a booster earlier than we oftentimes would do other vaccines, just in the hopes that we can provide some protection.
Thank you. What is meant by a partial responder to ATG?
So if you think about how we measure responses to IST, we have the complete response and the partial response. And that's just measuring where your blood counts get back to. So when we look at your platelets and when we look at your hemoglobin and when we look at your neutrophils, we want to see in a complete response that your counts have normalized or gone back to what they were before you had the aplastic anemia situation. Many patients, however, after IST tend to have what we call a partial response. So they're not needing transfusions and they're, able to live their life without really knowing that they have, lower counts, because their counts have recovered somewhat, but they haven't reached the thresholds that they were at prior to the aplastic anemia. And sometimes over time, that partial response will become a complete response. Sometimes that partial response just remains a partial response that is perfectly compatible with a good quality of life. And sometimes that partial response then relapses into cytopenias or lower counts that require transfusions and require further intervention.
Thank you. With kids returning back to school soon, this question is, when can kids return to normal physical activities?
So I tend to advise that they can do as much physical activity as that they can handle themselves. So, that doesn't mean that they can mix with other students or can go to school depending on how far they are from transplant. But if I'm discharging a patient home from the hospital after a transplant or after IST, if they want to go for walks, if they want to, shoot some hoops, whatever it is that they feel comfortable doing, I encourage them to do as much activity as they feel comfortable with, as is not tiring to them, to keep them conditioned, to keep their, sort of activity level going, and really to try and normalize this whole experience, which is, it's hard on the kids, it's hard on their psyche, it's hard for them to grapple with, a disease that sort of came out of nowhere for most of them. And to have gone through either IST or transplant in such a quick, sort of compressed time frame. And so being able to do some physical activity, let off a little bit of steam, recondition their bodies, I think is always helpful and a healthy thing for them to do.
How about playing contact sports? Is there like a medical criteria that you follow when you let kids engage in, say, like playing soccer or playing football, or things that may get them bumping around with other people?
Yes, so I want their platelets to be at least 50, if not a little bit higher than that, which is the first criteria, and that's both after IST and after transplant. They also have to be able to be around other people, so they need to have some of their immune function back, right, and need to meet those criteria, whatever those criteria are at the center at which they're being treated. And so, at our center, we follow criteria where if your T cell count meets a certain threshold several consecutive times, we would let you go back to school or let you interact with other children. And so in those patients, as long as they have platelet counts above 50, I'd be comfortable with them playing contact sports. I'd prefer that they not headbutt the ball, or if they wear or if they can wear a helmet if they're doing something where they may get some a hit to the head. But I, other than that, tackle football I will never say is okay. But other than that, contact sports, basketball, soccer, platelet counts greater than 50 would be my personal recommendation.
Thank you. Does puberty affect the bone marrow failure diseases?
So that's a good question. And we know that hormones are important in a variety of bone marrow failure diseases. In fact, hormone therapy or androgens are used for some of the inherited conditions like Fanconi anemia. They're also used, or they were used back in the day before widespread availability of ATG and of transplant in aplastic anemia. Nowadays, hormones are much less used in aplastic anemia because we have such better outcomes and such better options with both IST and bone marrow transplant. We do know that patients that go through puberty for a variety of reasons have a slightly, not a majorly significant, but a slightly higher risk of something called graft versus host disease when they get a bone marrow transplant. Now, that's not something that is specific to aplastic anemia, just more specific to bone marrow transplant. And so there is that sort of hormonal contribution there. However, I would say that in patients with aplastic anemia, given the variety of options that are out there for graft engineering, for post-transplant cyclophosphamide, and other ways of preventing graft versus host disease, that transplant, even after puberty, still remains a very attractive and good option for cure.
Thank you. What's the difference between cyclosporine and Prograf? Is one more superior than the other?
They're calcineurin inhibitors. They work pretty much the same way. So Prograf is just a trade name or brand name. Cyclosporin is the general name. In general, there's cyclosporin and tacrolimus. And then there's a variety of brands that make them. And some centers prefer cyclosporin, some centers prefer tac, some centers start with cyclosporin and then transition to tacrolimus. They're essentially not equivalent, but as close to equivalent as can be. And the reason we use one versus the other is depending on what was used in the study. for the data that was generated. So if cyclosporin was used with ATG for immunosuppression therapy, that's why most centers will still use cyclosporin. And then depending on which center you may go to for a bone marrow transplant, some might use cyclosporin, some might use tacrolimus, some might use cyclosporin for the first month and then transition to tacrolimus when you get discharged home. So almost interchangeable.
Thank you. Is it common for the platelets to be the last to respond after using ATG, cyclosporin, and ultramapag? And why is that, if so?
So I have seen every iteration of counts coming back, from platelets being the first to respond to platelets being the last to respond. You know, I think it just is actually dependent on the person, dependent on, you know, the individual characteristics of the aplastic anemia, the immune, you know, sort of what was the immune directed pathology there, how the response is happening. You know, I oftentimes, or I personally don't use ultramapag in pediatric patients with aplastic anemia based on the data that was presented from the NIH trial. So I can't speak to experience with patients that are getting IST plus ultramapag. But in, you know, traditional IST with ATG and cyclosporin, I really have seen a whole different variety of count recovery. I will say that oftentimes I'll see some recovery in the platelets, whereas you don't need transfusions as often, but you may not normalize your platelets as quick as, say, you normalize your neutrophil count. But the important aspect there is that you're not needing the platelet transfusions, because the more transfusions you get, the more likely you are to react to future transfusions. And also it does at some point make transplant become a little bit more difficult because you are being exposed to all those different antigens.
Thank you. Is it possible to have more than one transplant?
It is definitely possible, though not desirable. So if a patient does, you know, have a graft rejection event after transplant for aplastic anemia, or what, you know, which is the same thing as a relapse of their aplastic anemia, because graft rejection is essentially a T-cell mediated destruction of the graft. We can and have given second transplants with good efficacy and good results. It's obviously not ideal, but it is definitely possible, and it can definitely be successful.
Is there an increased risk of graft versus host disease with a second transplant?
So there is an overall increased risk of morbidity and mortality with a second transplant, and part of that is graft versus host disease, and part of that is infection from, you know, being neutropenic for so long. And part of that is being, you know, getting exposed to additional chemotherapeutic agents. So second transplants are not necessarily easy, but we do have good success rates with them, not as good as upfront transplant, but definitely good success rates.
And I think you may have answered this in some previous questions, but I'll ask this anyway. What is the difference between a mismatched transplant and an unrelated transplant?
Right. So when we look at those HLA alleles that I mentioned, right, we're looking to match them all. And so again, the gold standard is always the matched sibling, right? So if you have a sibling who's a match at all of those loci, that's your answer. You're going to get treated with a matched sibling transplant. And then there are several different potentials or possibilities. And again, one is not necessarily better than the other. It sort of depends on center expertise and a variety of other factors. You can have a matched unrelated donor. So this is a donor that's not related to the patient, but has all of the same HLA molecules, and that's a matched unrelated donor. And that can either be a 10 of 10 or an 8 of 8, again, depending on the center that you're at. And then you can have what's called a mismatched unrelated donor. And again, you can have a mismatch at any of those alleles and be either a 9 of 10, an 8 of 10, a 7 of 8 that's a 9 of 10, or a 7 of 8 that's an 8 of 10. And any of those would be acceptable, again, for a mismatched unrelated donor transplant. The other mismatch that you can have is what's called a haploidentical transplant. And what that means is you're using a related donor usually, right? So this is not an unrelated donor, but rather a related donor, most often a parent, or in the case of a child, because each parent has given, one haplotype to the child. So each of those alleles in the HLA, so the A, the B, the C, the PRDQTP, you got one of those from mom and one of those from dad. And so each parent should be a half match or a haplo match, right? And so you can be mismatched at multiple matches for a haploidentical transplant. But there's a lot of other minor, what we call minor antigens or minor loci that we don't check, that you'll also likely have more of a match with your parent than you would with an unrelated donor. And so some centers would prefer to use the haploidentical approach. So you can have a mismatched related donor, you can have a mismatched unrelated donor, you can have a matched related donor or a matched sibling usually, and you can have a matched unrelated donor. So the relation is obviously if you're related or not, and then the matching is, do those 10 loci match or 8 loci match, or do they not?
Thank you. Our next question is, my son has been diagnosed with aplastic anemia and also has a small PNH clone. We're heading to transplant. Does that mean he'll also be cured of PNH as well as the aplastic anemia?
Yeah, so one of the most common clonal or somatic changes that we see in aplastic anemia is in fact the PNH clones. Present in about 40% of patients, at least in the data series that I just went through of almost 100 pediatric patients. And that's sort of commiserate with other data sets that have been either published or presented. So the nice thing about transplant is that it'll take care of both the aplastic anemia and the PNH clone. Depending on how big the PNH clone is, your transplant physician may try to give a little bit of extra therapy on the front end to ameliorate the PNH clone completely. So for instance, on the clinical trial that we did using T-cell depletion, we would give TBI or some radiation of 200 centigrade in our protocol. However, if you had a PNH clone that was greater than 10%, we would increase that radiation to 300 centigrade. So not a huge jump at all, but a small jump. And that was to make sure that we got rid of the PNH in its entirety. And so, I think it's obviously patient specific and how big the clone is. But your transplant physician will definitely take that into account when designing the conditioning regimen that they use.
Thank you. This question is, we've been out of immunosuppressant therapy for 3 years, and we're still doing well with our counts. How far out do we need to be when we can stop worrying about a relapse?
So the further you get out, the better. And just to clarify, I don't know if this is immune suppression, after transplant, because we do use immune suppression after transplant, or immune suppression as IST, but in both cases, being off of immune suppression therapy and proving that your counts are good is always a good sign of not having a high probability of relapsing. Again, I don't know your own personal situation, but if you have a CR and are off immune suppression for 3 years, I would think that you are in pretty good shape and need to worry a lot less about potential for relapse. And I hedge my bets there because, there's always the 1 in a million, and I don't want to be the one to tell you, oh, 100% not, or especially not, without being able to see the records and whatnot. But there's always that 1 in a million chance. But again, the longer you get out, the less you have to worry.
Thank you. This question, it goes back to the question about puberty. And is it common for physicians to prescribe medications to stop menstrual cycles?
So we do that when the platelets are really low, or if you're going through transplant, because the bleeding can get very significant and very severe because you don't have the ability to clot it off. So oftentimes we will use it for a short period of time until we're able to get the platelets to a better place, and the patient can get their ability to clot off the bleeding, or really control the bleeding. So that's why we sometimes will consider using either birth control or other methods of hormonal control during the acute phase of the aplastic anemia treatment.
Thank you. And for live vaccines, is there a rule for live vaccines for patients? And do patients need to be concerned about being near siblings who have had like a live vaccine as part of pediatric vaccines?
So that's a good question. And there's no right answer. It's again center specific, depending on how your center has set up their revaccination schedule, and what parameters they use. Some use time from transplant, like they will start revaccinating at 1 year post-transplant. Some use immune reconstitution. So when does your immune system sort of regain its ability to recognize antigens, or what number of T cells do you have, or whatever measurement they're using to start the vaccine schedule. Now, usually we'll start with, not live vaccines, or usually protein vaccines. Make sure that you have an adequate response to that, and then move on to the live vaccines. But there's no sort of set in stone time that all centers are following. With regard to, a sibling getting a live vaccine, again, it depends on where you are in your treatment sort of regimen. So if you're actively getting transplant or immediately after transplant, I would say keep the sibling away for the first couple of weeks after the vaccine. But the issue is, and I tell all of the patients that I do transplant to, you also personally can't live in a bubble, and the family can't be expected to live in a bubble. And so the siblings need to get their vaccines. They need to be protected. And I think what I try to convey to my patients is, common sense goes a long way in preventing infection and things like that. So if you're going to get a live vaccine and you have a sibling at home that's 35 days post-transplant, keeping that sibling away from the transplanted sibling for 2 or 3 weeks might be the best thing to do. If, on the other hand, you're a year post-transplant with good T cell function, then that separation is obviously not needed. So it again depends on your circumstances.
This question is regarding moderate aplastic anemia, which is kind of a dilemma. When to treat, not to treat. How does one decide?
Again, a dilemma, so no clear decision there. What I generally will do is follow the counts, talk to the family, discuss with the family, see which way it looks like it's going. Oftentimes it'll declare itself at some point, either yes or no. Now, if you're needing recurring transfusions, right, there's not an urgency to decide, but at some point, right, you're going to start getting a decent number of transfusions that will make transplant harder. So if your transfusion frequency is, not high, but you're getting transfused with some regularity, I'll have a different discussion than if you're a moderate aplastic anemia patient that needs a transfusion here, and then doesn't need one for 3 months and is just living with lower counts, but is doing fine. And then we're just monitoring counts. So again, it sort of depends on your personal clinical sort of story, but there's a gray area where I think a lot of family input is important, parental input is important. We have to think very carefully about the decision to treat. These are not benign treatments, right? They all have significant side effects. And so we want to be thoughtful about moving forward with treatment, but we also want to be thoughtful about, needing to, again, keep these patients living as normal and healthy a life as possible. And if that means that they would benefit from treatment, then making that decision as well.
Thank you. Does the number of transfusions impact the success of immunosuppressive therapy or transplant?
So the number of transfusions doesn't necessarily impact the success of immune suppression therapy. However, as I've alluded to earlier in the discussion, the number of transfusions can make transplant slightly harder. And the way that happens is as you get exposed to more and more units of blood product, you can develop antibodies against, antigens that are expressed on the red cells or on platelets or whatnot, depending on what you're being transfused with. And those antibodies can be antibodies that may recognize similar alleles or antigens on a potential donor. And so you can imagine that if your body has antibodies against the donor cells that we're going to put in, that can make transplant significantly more difficult. Not impossible, right? We have ways of depleting the antibodies and then moving forward with transplant, but it's definitely not a situation that we want to find ourselves in. That said, if you need a transfusion, you need to get the transfusion. So that should not preclude you from getting the blood or platelets that you need. But it sort of behooves us as physicians to be thoughtful about parameters that we set for transfusions and the frequency in which we're giving transfusions.
Thank you. Is there really a difference between severe aplastic anemia and very severe aplastic anemia?
In my mind, I think it's more nomenclature and how we divide things more for studies and things like that. I think in the sort of in the patient view and in the therapeutic interventions and what's available, less so. The one thing that it does sort of tell me is that we need to move quicker in the very severes, just because, the risk of opportunistic infection and fungal infection in particular is directly related to both the depth or the sort of the number of neutropenia, right? So how neutropenic are you? Do you have a neutropenia of in absolute neutrophil count of 200, or are you at 0, right? There is some protection to having neutrophils of 200. And if so, how long have you been neutropenic for, right? So it's the depth of neutropenia and the time of neutropenia. And that is, sort of what determines your risk for some of these opportunistic infections. So if you have a neutrophil count of 0, I really don't want you going for very long with that neutrophil count, right? There's not a lot of wiggle room. It just means we have to move to whatever definitive therapy we're going to use. So either IST or transplant. So that decision needs to be made, and we need to, activate whichever pathway we're going to go down.
Load ever a concern for kids who are using a lot of transfusions, and is there treatment for that?
So the concern is the development, number one, of the donor-specific antibodies. And the second concern is if you're getting a significant number of red cell transfusions, you may find that you're becoming iron overloaded. So the treatment for iron overload is chelation therapy, right? We can chelate the iron out. Again, not something that we want to have happen to our aplastic anemia patients, but something that we have a lot of experience from in other chronic illnesses that require chronic transfusion. So we're able to remedy that. better to prevent it from happening than to have to treat it. But again, if we find ourselves in that situation, we're able to treat it. The second is to deplete the antibodies from the transfusion if we're going to move to transplant. So if you have significant antibodies that you formed against the antigens on the red cell transfusions or the platelet transfusions, we may need to consider using some agents to deplete those antibodies before moving to transplant if you choose to do transplant over immune suppression therapy. Now, the fact that you have donor-specific antibodies from transfusions may push the physician or the family or both to recommend immune suppression therapy over transplant, or it may push the physician and the family to say, there's a risk of us needing more transfusions if we do immune suppression therapy, which will only make transplant even harder. Maybe we should just, deplete the antibody and go to transplant. So again, a very personal decision between the family and the physician and the treating team, but something that's very good to keep in the back of your mind and think about.
Thank you. For family members who have not been a donor, is there a reason why they should not donate blood?
Sorry,
Until
you
after
cut out
they've
for a
been,
minute.
sorry, Dr. Oved. The question was for family members who have not been screened yet to be a potential donor, but they'd like to donate blood. Is there a reason not to do the blood donation until after they've been ruled out as a donor?
So evidence has shown and data has shown that donor patient directed donations actually have worse outcomes than using blood from the available banks. So I would not recommend directed donations just based on the available data. And there's a lot of different reasons for that, but it's sort of hard to recommend that particular avenue when the studies have shown that there are worse outcomes with that for the patient.
Thank you. My son is one of 5 siblings. None of the siblings are a match. How common is that?
Unfortunately, not the first time I've heard of 5 or 6 or even 7 siblings and none being a match. So you have a 25% chance of being a match with each sibling that you have. And I should specify that it's each full sibling that you have. And so there's a 25% chance. Now, obviously, the more siblings that you have, the higher the chance of finding at least one potential match. But there is the potential for not having a match even with 4 or 5 siblings, just given those percentages.
Thank you. Is fertility preservation recommended prior to transplant, if possible?
So I think that's a very personal decision. It also, I think, matters where you are at transplant and what your conditioning regimen is going to look like. So if you are postpubertal and can either egg harvest or sperm bank, then I think that is a very reasonable thing to do. If you're prepubertal and there are ovarian tissue harvests or testicular biopsies that are done at your institution, that is something to consider. But again, a very personal decision as there's no data yet to support that we will be able to use those in 10 or 15 years for fertility. The other thing to consider is, what does the conditioning regimen look like? And is it really an infertility causing conditioning regimen, or is there a probability that there may be some fertility left? And again, it depends on if you're pre or post-pubertal at the time of the conditioning regimen. But some centers are using, fertility sparing regimens. Again, not 100% successful at maintaining fertility, but definitely better than prior regimens. So again, very specific to each person's circumstances and the center at which they're being treated and what's available at those centers.
Thank you. This question is, my daughter's stem cells from a donor are coming from Germany. Are they frozen? How do they get here safely?
So they don't necessarily need to be frozen. They'll be kept on ice. I had donated stem cells 6 years ago for a patient that was in, I believe it was Spain, but it was somewhere in Europe, and they collected, threw them on ice and took them on the next flight out. We get them just fine. And then, because of the COVID pandemic, a lot of centers and the NMDP was actually recommending that we actually get the product and cryopreserve it or freeze it before we start conditioning regimens, just in case we weren't able to get the graft because there was no flight or, all of the different, sort of things that have happened during the pandemic. And so a lot of centers have been cryopreserving grafts, either international, domestic, or both, throughout the pandemic. And we know that we can do that, and that we can then thaw the cells and they're viable. Of course, fresh grafts are always preferable, but we can work with cryopreserved grafts just as well.
Thank you. If you need a second transplant, and the donor for the first transplant is able and willing, is it recommended to use them again? What are the pros and cons of using the same donor?
So I think it depends, on why the graft didn't take the first time. If it was an immunologic rejection, then chances are it's probably better not to use the same donor and think about a second donor. But if it was a graft failure because of certain other reasons, let's say the cell count wasn't great because of X, Y, or Z, then it might be reasonable to think about using the same donor. The other thing to consider is what other donor options are there. So depending on if there are other donor options, and what they look like, I think all of those things need to be taken into account when making that decision.
And our last question is, part of the transplant regimen is there also a look at prevention of GVHD?
Definitely. And so again, depending on the center that you're at and depending on what kind of graft you're using, there's always some component of GVHD prophylaxis. So just to name a couple, if you look at the haploidentical approach, say at Hopkins, right, they use what's called post-transplant cyclophosphamide as their GVHD prophylaxis, and they sort of couple that with MMF and tacrolimus, and that combination gives you the graft versus host disease protection in the haplo setting. On the study that we did, we used T-cell depletion. So we depleted out a subset of T cells in the graft before we put the graft in. And those are called the alpha beta T cells. And that was the GVHD prevention, right? We took out the cells that may cause GVHD and then put the rest of the graft in. So again, it just depends on what center you're at and what the graft that's available is. And then we take into account all of those different parameters, as well as if we can get marrow or peripheral stem cells, and then we come up with a personalized approach to how we're going to do graft versus host disease prevention. So again, either pharmacologic with post-transplant cyclophosphamide or something like that, or we might use, T-cell depletion and graft engineering, upfront, so that there's no pharmacologic intervention on the back end for graft versus host disease prevention. And both work just, excellent. So
Thank you so much, Dr. Oved, for sharing your time and your expertise with all of us and answering all of these great questions from everyone. And if you'd like to watch this webinar again at a later time, it will be available on our website within 3 to 5 business days. If you have any additional questions, please feel free to send it to us in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit your question to our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 39 years. This concludes our program. Thank you again, Dr. Oved.
Thank you.